Assalamu alaikum wa rahmatullahi wa barakatuh. Dear viewers, listeners, and audience, Jazakumullah khairan for joining us on this presentation here, hosted by a number of health professionals and ulama. And alhamdulillah, the intent and the purpose being that COVID-19, which has obviously captured the attention of the global community, if it's the first time that you're hearing about C19, well, welcome from your sojourn under a rock somewhere in the world. But I trust, alhamdulillah, you probably would have heard heard of it by now. And South Africa has been in a state of lockdown as well as many other countries of the world. But as the knowledge regarding C19 and the management of C19 progresses, lockdowns globally are beginning to ease. We've seen New Zealand today come down to level 1. Where everything, practically most social activities, with the exception of international travel, having resumed. Other countries of the world have tabled a resumption of activities which most likely will occur in a few days. South Africa being no different. Management of the disease, of course, being critical. Management of the situation by the population, government and healthcare professionals will tell that inshallah in the next few days where we are. Welcome once again to this presentation, not only for our Muslim listeners, but for those who are joining us on other platforms as well. I believe UKZN has got a platform as well. And we can see a number of names out there from different members of the community. We will trust and we hope that the information disseminated and distributed during the course of our discussion will be general. It will be beneficial for all as we return to schools, workplaces, places of congregation, places of worship, and other social events and community events which are inevitable, hopefully sooner rather than later. Of course, the management of the disease being critical. To begin our proceedings this evening, we call on Qari Zakaria Matiani, who will render us a recitation of the Quran Kareem. Qari Zakaria completed his hifz under Hafiz Muhammad Hafizi, completed the Alim program in Darul Zakaria, completed his Sabah under Sheikh Ahmed Askar Abul Mun'im, and is currently the Imam of Pakalani Masjid in Botswana and an educator at Al Nur School in Gaborone. Qari Zakaria, Assalamu alaikum, Jazakumullah khairan. Please render us our recitation of the Quran Kareem.
Wa alaikum salam. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم تبارك الذي بيده الملك وهو على كل شيء قدير الذي خلق الموت والحياة ليبلوكم أيكم أحسن عملا وهو العزيز الغفور الذي خلق 7 سماوات طباقا ما ترى في خلق الرحمن من تفاوت فارجع البصر هل ترى من فطور ثم ارجع البصر كرتين ينقلب إليك البصر خاسئا وهو حسير ولقد زينا السماء الدنيا بمصابيح وجعلناها رجوما للشياطين وأعتدنا لهم عذاب السعير وللذين كفروا بربهم عذاب جهنم وبئس المصير إذا ألقوا فيها سمعوا لها شهيقا وهي تفور تكاد تميز من الغيظ كلما ألقي فيها فوج سألهم خزنتها ألم يأتكم نذير قالوا بلى قد جاءنا نذير فكذبنا وقلنا ما نزل الله من شيء إن أنتم إلا في ضلال كبير وقالوا لو كنا نسمع أو نعقل ما كنا في أصحاب السعير فاعترفوا بذنبهم فسحقا لأصحاب السعير إن الذين يخشون ربهم بالغيب لهم مغفرة وأجر كبير وأسروا قولكم أو اجهروا به إنه عليم بذات الصدور ألا يعلم من خلق وهو اللطيف الخبير هو الذي جعل لكم الأرض ذلولا فامشوا في مناكبها وكلوا من رزقه وإليه النشور أأمنتم من في السماء أن يخسف بكم الأرض فإذا هي تمور أم أمنتم من في السماء أن يرسل عليكم حاصبا فستعلمون كيف نذير ولقد كذب الذين من قبلهم فكيف كان نكير أولم يروا إلى الطير فوقهم صافات ويقبض ما يمسكهن إلا الرحمن إنه بكل شيء بصير أمن هذا الذي هو جند لكم ينصركم من دون الرحمن إن الكافرون إلا في غرور أمن هذا الذي يرزقكم إن أمسك رزقه بل لجوا في عتو ونفور أفمن يمشي مكبا على وجهه أهدى من يمشي سويا على صراط مستقيم قل هو الذي أنشأكم وجعل لكم السمع والأبصار والأفئدة قليلا ما تشكرون قل هو الذي ذرأكم في الأرض وإليه تحشرون ويقولون متى هذا الوعد إن كنتم صادقين قل إنما العلم عند الله وإنما أنا نذير مبين فلما رأوه زلفة سيئت وجوه الذين كفروا وقيل هذا الذي كنتم به تدعون قل أرأيتم إن أهلكني الله ومن معي أو رحمنا فمن يجير الكافرين من عذاب أليم قل هو الرحمن آمنا به وعليه توكلنا فستعلمون من هو في ضلال مبين قل أرأيتم إن أصبح ماؤكم غورا فمن يأتيكم بماء معين صدق الله العظيم.
MashaAllah, Allahumma zid fazid. Jazakumullah khairan, Sheikh Zakaria, for that recitation. In Surah Mulk, Allah subhanahu wa ta'ala says, خَلَقَ الْمَوْتَ وَالْحَيَاةَ لِيَبْلُوَكُمْ, that He created life and death so He may test you. life, death, and everything in between, from situations, health concerns, etc., are all tests from Allah subhanahu wa ta'ala. And a believer responds likewise, treating them as tests from Allah subhanahu wa ta'ala and managing them within the confines of the lessons taught to us by Allah subhanahu wa ta'ala and in our illustrious deen. I'm pleased to call on our next presenter for this evening, Professor Yunus Moosa. Professor Yunus Moosa is an associate professor, chief specialist, and head of department at the Infectious Diseases Department of UKZN. Professor Moosa, alhamdulillah, has been, well, we would say at the forefront of the discussions around C19, the management of C19. The specific angle that Professor Moosa will be talking to us this evening on is COVID-19 dynamics and ultimate management of the disease itself. That COVID-19 has proven to be unique in its in its management, in its dynamics and understanding, and how is it going to be managed going forward in the current days as well as the days ahead. Professor Yunus Moosa, can you take it away? Assalamu alaikum wa rahmatullahi wa barakatuh. Professor Moosa?
Okay, can you hear me?
We can hear you loud and clear.
Oh, great. I'm sorry, I was trying to get myself unmuted. So I'm just going to go ahead and share my screen in the meantime. All right, thank you. All right. Am I all good?
You're all good.
Excellent. Thank you. Thank you so much for inviting me to participate in this program. I'd like at the outset to say that there are no experts on COVID. We are all students of medical science, and I, for one, have some understanding of infectious diseases. I have an understanding of disease processes, and I'm trying to put all of that knowledge and years of experience into understanding the COVID epidemic, and therefore, I'm trying to give you an understanding of the disease as well. What I plan to do in this presentation is highlight some of the important aspects of COVID, keeping it as simple as possible, keeping in mind that we have a mixed audience, and therefore we'll try and stay out of technical details. All right, can you all see my first slide?
Yes, doctor.
All right, great. All right, so to begin, let's talk about how COVID is transmitted, or how the SARS coronavirus 2 is transmitted. I think this is important for people to understand the mechanisms of transmission, because it will allay many of their fears and also allow them to be on guard so that they are able to protect themselves. This is essentially a respiratory virus, which means that the source of the virus from an infected person is from their saliva, essentially. So if individuals either speak, sneeze, cough, or engage in any activity that results in the mouth opening and spraying out a fine spray of saliva, whenever anyone talks, there is this fine spray of saliva that does come out. Nobody can actually feel it because it's such a tiny spray. Within that spray, in the droplets of that spray, virus particles can be found, and that is the source of the infection. Now, the viral particles need to fall on parts of the individual that is within a fair distance of the person who is infected, so that these spray particles will settle on mucosal surfaces. And the mucosal surfaces are essentially the eyes, the nose, and the mouth. If it falls on skin, the person will not get infected. It has to fall onto mucosal surfaces, which are the vulnerable spots. It's sort of the T zone of the face. These viral particles, once they settle on those areas, they will be able to enter the system of the patient and set up infection. The other way in which these infections can occur is that the spray of viral particles that is emitted from the mouth during any of those activities will fall in the vicinity of that individual. Since these are heavy viral particles, they generally do not carry beyond 1 meter to 2 meters from the individual who's coughing. So really speaking, if you are standing more than 2 meters away from somebody who is speaking to you or coughs, you are safe because this fine spray will not reach you. If you within that distance, then there is the possibility that these viral particles will settle on your surfaces and cause infection. The other mode of transmission is that particles, objects in the vicinity of the 1 to 2 meters of that person will also get contaminated by viral particles, because the spray of viral particles will settle on those inanimate objects, be it a door handle, be it a desktop, be it a utensils on a table, whatever it is. The spray of particles will settle which contain virus, and they will remain infectious for a variable period of time. And if somebody touches any of those surfaces, then their hands get contaminated. But they will still not get infected, even though their hands are contaminated, because, like I said earlier, these particles have to get into contact with mucosal surfaces. So if they touch their face, especially their eyes, they pick on their nose, they suck on their fingers, then they will get infected. That's why the emphasis you will notice is on wearing a mask, because then you will have less of a spray that is spread around. Washing your hands frequently, because those are the appendages that are more likely to touch inanimate contaminated surfaces and then move those infected particles to the eyes or the mouth or the face. That's why we also have the emphasis of cleaning surfaces that are frequently touched in the vicinity of an infected person. So understanding this mechanism will make you realize why we take the precautions and why we make the recommendations in many of these cases. The next question that should be popping into your mind is that if it falls onto inanimate surfaces around the infected individual and therefore contaminating these surfaces and making them a potential source for infecting yourself, or alternatively, somebody can touch on these inanimate objects, go across to somebody, shake hands with that person will now have the virus transmitted to their hands and they can infect themselves. So you could be a primary individual infecting yourself, or you could secondarily infect somebody else. The question that should come to mind is, how long are these surfaces that are contaminated infectious? Now, this depends on several factors. Number one is the humidity of the environment, the temperature of the environment, and the nature of the surface. All of these variables will determine how long a particular surface that is contaminated will remain infectious, because viable virus is on that surface. And if you look at the slide, it is very variable. Plastics can have the virus being viable for 2 to 3 days, steel for 2 to 3 days, copper for 4 hours. So in general, we say 3 to 5 days. Nobody's going to remember exactly how long on all of these surfaces. So for example, in a hospital setting, if you close up a unit where there was a patient and you keep it closed for 5 days, for all intents and purposes, you will not have any viable virus, because after 3 days, most viral particles would have died by then and therefore not be able to infect anyone. So, having understand that, now you will understand why we take the infection prevention control measures that we talk about. So let's talk about the viral dynamics. In other words, if somebody is infected, how long is that person infectious for? Number one. Number two is that if they are infectious, how long would it take for that infectiousness to wane? If you look at the first graph on the top left-hand corner, this is a graph that shows the time on the x-axis and the amount of virus in the secretions of that individual. And you will note that as you move away from the date of symptom onset, if you look at day 18, 19, 20, where I got the small squares, you will notice that most people, the viral particles are much fewer than in individuals that are early in their infection, which is suggesting that people are most infectious early on. The reason being is because they are secreting a lot of virus in that spray that I talked about. What is interesting in coronavirus 2, which is unique compared to the SARS virus that we experienced in 2002 or the MERS virus that we experienced in 2012, is that the SARS coronavirus 2 is infectious in an individual infected with the SARS coronavirus 2 is infectious a few days before they become symptomatic, which creates a huge challenge because an individual will look perfectly well, have no symptoms, and yet be incubating the virus and has the real possibility of disseminating that virus to people around them. And some studies have shown that almost half the amount of transmission that occurs in people that are pre-symptomatic. That is, secreting their virus in their secretions before they develop symptoms. And as you know, it is symptoms that brings the person, that highlights which individual is potentially an infectious source. So this creates a lot of anxiety amongst healthcare workers, amongst hospitals, because they could be admitting people who are pre-symptomatic, who show no evidence at all of having the infection, but yet could come into a healthcare environment and start spreading the disease unwitting to anyone within the hospital or to the patient themselves. Now, you must remember, detecting the virus in the upper respiratory tract doesn't necessarily mean that the virus is alive, because the test we use to detect the virus in the upper respiratory tract is looking for the genetic material. Whether a virus is alive or dead, there will be genetic material. So the fact that there is genetic material doesn't necessarily mean that the person is infectious. So what scientists try to do is look at cultures where they take these upper respiratory tract samples and try and grow the virus. Clearly, if the virus grows, that means it is alive. If it is alive, then it can cause infection. And what they found, interestingly, is that generally after 8 days of in symptoms onset, they were unable to culture the virus, which suggests that if you go around 8 days after the person onset of illness, they are not infectious. So roughly speaking, we've decided that about 2 to 3 days before symptom onset, up to about 8 days post-symptom onset is the time when people are most infectious. We in the medical fraternity have decided to place the bar a little bit higher and say that if an individual is 14 days after onset of symptoms, that they are non-infectious. So you will find that many of the guidelines will say that if an individual is now 14 days post-onset of symptoms, even if they have symptoms, be it cough, be it lethargy, pain, aches and pains, we would still consider them non-infectious because no one has managed to culture the virus beyond that period. So hopefully this will give you some idea of the dynamics of the virus in an infected person. Right. The other problem with the SARS coronavirus 2 is that they are asymptomatic patients. Patients will have no evidence of disease whatsoever, but yet have the virus and are potentially infectious. And in fact, in the Diamond Princess cruise study, where they had individuals that were all tested at regular intervals while on the ship, they found around 20% of people had no symptoms whatsoever, but had virus in their upper respiratory tract and were infectious. So it is estimated, depending on which studies you look at, that up to 50% of individuals can have asymptomatic infections and become a source of transmitting the virus. So just using symptoms alone is not good enough to identify people who are at risk for transmitting the disease. People without symptoms or just before they develop symptoms can also be a source of infection, which also creates anxiety. If you're thinking about our approach to taking people going to the masjid, we often emphasize so much on symptoms as being a reason to exclude them from the masjid. Now you can understand that people can come into a masjid not having any symptoms whatsoever, but yet have the possibility of transmitting the virus. People often know influenza as a common respiratory tract virus, so I thought a slide comparing those two infections would be instructive. So if you look at the number of people that one person with influenza would infect compared to the number of people that somebody with COVID would infect, there are at least 2 to 3 times more people infected with COVID than with flu from one person with that infection. The other thing is look at the incubation period, 1 to 14 days. That means an individual can be exposed to somebody with COVID and would only develop symptoms 14 days later, which becomes a huge problem in trying to trace the contacts of these people. You could remember who you met quite accurately in the last few days, but if you go back 2 weeks, very few people would remember who they interacted with and who could have been the potential source for them to have got infected. So it becomes far more challenging to contain the spread of this infection by detecting the source and detecting other contacts. If you look at the hospitalization rate, many more patients that have COVID require hospitalization because it causes a far more serious disease. And if you look at the case fatality rate, it's about 10 to 20 times higher in COVID than in influenza. So just to give you a sense that this disease is much more serious than influenza. What type of symptoms people with COVID present? What I would like you to focus on is none of these symptoms are found in 100% of patients. And if you scan all of these symptoms, these are very common symptoms that are found in people in general, not only with COVID, which means that often patients can have symptoms that could suggest COVID and not have COVID. And patients that have COVID do not have a particular symptom that you can say is definitely COVID, which makes the diagnosis and detection of these patients very challenging. Cough is a common symptom. Now that we have a flu season, you can see many of these symptoms occur with flu. So soon we are going to have huge problems in differentiating between who has influenza and who has the COVID infection. If you look at the spectrum of disease, most people that have COVID will have mild disease. A minority of about 15% will have severe disease. Those are the ones that are more likely to get admitted to hospital. And then an even smaller minority of about 5% will be critically ill. And the mortality is estimated to be around 1 to 3%. Compare that to influenza, which is 0.1%. Now, the important thing is that not everyone is equally at risk of dying from COVID. The people that are most likely at risk of dying from COVID are people who are older and people who have got comorbidities. That means they've got diseases that compromise their ability to handle any serious infection that they are exposed to. And the ones that are concerned about a chronic lung disease, including asthmatics, in the Muslim population and in the general population, chronic heart disease, diabetes, hypertension are very common diseases. Obesity is another risk factor. So these are the types of people that we want to protect from getting COVID because their risk of dying is much higher than the general population. And I thought I'll include the slide showing the risk of age. Age is the strongest factor that's correlated with mortality. However, if you look at an 80-year-old, they have a 15% chance of dying, which means that 85% of these patients will recover. So it's not doom and gloom, but if you look at the risk of a 19-year-old of dying is 0.2%. So there is over a 30-fold higher risk of somebody that is 80 years old of dying from COVID compared to somebody who is 19 years old, which is a huge increase in risk of mortality. How do we manage this disease? We don't have an established treatment for this. So what I would like to do is just give you an overall sense of how we would approach this. There are two ways in which you approach this. Is number one, when you have diagnosed somebody with COVID, you want to actually protect others from getting infected. So it becomes an important principle that these patients need to be isolated so that they protect people who are haven't experienced this infection from getting the infection. The second part of the management is to treat this patient and therefore help them feel better, get better, and have a positive outcome. Essentially, it is supportive treatment. If they have fever, we use antipyretics. If they have aches and pains, we use analgesics. If respiration becomes a problem, we give them oxygen via mask and then slowly escalate the amount of oxygen we need to give them, depending on how seriously the lungs have been affected. If the patient has developing at high risk for developing clots, then we give them anticoagulants. But in general, all drugs that are now touted as possible therapeutic agents for COVID are experimental, which means that we have no evidence that the treatment will definitely work. And many of these drugs have toxicity attached to them. And we don't know what the risk-benefit ratio of using these drugs is. So the current recommendation within South Africa is that these drugs should only be used in the setting of a study. Other than that, we should go with symptomatic treatment, supportive measurement, and treat complications as they arise. Finally, I thought I'll just touch on this last slide of mine that got to do with herd immunity. I mean, clearly you must be thinking that if we have got coronavirus in our population, then is this virus going to stick around forever? Do people who get infection are they protected from getting infected again? In other words, do they develop adequate immunity so that they are able to fight off a second attack of an infection? And right now, the scientific community is not clear. The virus has only been around for about 5 months now. And we haven't had enough time to study what happens to people when they are re-exposed to the virus, and what can we expect in 6 months, a year, 2 years, 3 years down the line. Most scientists believe that we will have immunity. Many people are hoping it will be lifelong immunity, but at the very least, we expect immunity to last a few years. So if an individual is immune, then this concept of herd immunity becomes important. Herd immunity really means that people within a population, the people who have immunity within a population will be able to protect people in that population who don't have immunity by virtue of the numbers of people that have immunity. So if you look at this graph, if you look at this figure, in the first upper figure, you will notice that most people in that population don't have any protection. And if this one person enters that population with infection, then that infection spreads wildly, and you find that most of the population get infected. This is where we are at the moment, where there is no herd immunity, that individuals will spread the virus around to many others that don't have immunity and therefore cause mass infection. The whole idea, and Ozayr is going to come to that, about flattening the curve, is that we're trying to prevent the number of people within the population getting infected and getting sick, so that we allow our healthcare facilities not to be overwhelmed. What we are hoping to happen in the next 6 months to a year is the bottom figure, where most people have got immunity. As you can see, the darker blues are all those that have been exposed to the virus. They have immunity. There will be numbers of individuals within that have no immunity. So when somebody with an infection enters that population, the people who don't have immunity will be shielded by people with immunity, and therefore are less likely to get infected by an infected person getting in there. By protecting our elderly now from getting infected, we're hoping that enough herd immunity will be created in the population so that even if we don't have a vaccine, the elderly will be protected from getting infected because of herd immunity. I'm happy to take questions later on. I think at this point, Ozayr will take over and give his presentation, and we'll take it from there. Thank you very much.
Jazakumullah khairan, Dr. Yunus, Professor Yunus Moosa, for that presentation. And indeed, I'm sure we'll have some questions about that a little later on. But as you rightfully said, Professor, next our presenter is Dr. Ozayr Mahomed. Dr. Ozayr is a public health specialist at UKZN. Seems to be a UKZN fest tonight, but all's good, alhamdulillah. And Dr. Ozayr will be presenting on COVID-19, C19, from a public health perspective. Now, this is very important from a public health perspective, that how would we manage it in areas of collective importance, the workplace, as we had suggested early on, schools, all of whom represent public venues. Do we close down public venues? When we return back to work, obviously there are going to be C19 cases or incidences that are going to arise in a public space. How will such an individual be dealt with? How will such an individual be supervised? How will screening be taking place at public venues and public facilities to ensure that symptomatic individuals are identified before they gain entry into a social space, which happens to be a concern of many in the health professional environment? Assalamu alaikum, Dr. Ozayr Mahomed. You can take it from there, inshallah.
Walaikum salam wa rahmatullahi wa barakatuh. Jazakumullahu khairan, Moulana, for this opportunity. My discussion this evening is, I'm going to try to cut on time. I see the time is very limited, but it's going to focus on a few points. The first part is to present where we are at the moment. What is the situation? The second few slides will talk about a phenomenon when people are developing policies, because we are all very impatient and we want immediate solutions. And the last few slides will talk about what should be our actions now that the number of cases is actually increasing. So just quickly going through some of the slides is that if we look at by this morning at about 9:30, the global figures sat around 7 million cases. If we go to the right hand side or my right hand side of the slide, and you'll see that 50% of those cases are still active. But when you look at the severity, as Yunus pointed out, that at this point in time, only 2% of the global numbers are serious or critical cases, and up to 10% of the cases have passed on. Now, just released in the last few minutes, South Africa has crossed the 50,000 mark. And if we look at the last few days, you would notice that on average, we've been increasing by about 2,500 minimum every day. If we consider that what we're detecting is 1 out of 4 people, that means there are still another 10,000 new cases sitting out there in the community that we haven't actually diagnosed. Worryingly or increasingly, you see that the mortality has actually passed 1,000 as well. 1,000 deaths directly related to COVID. We all know that Cape Town or Western Cape is at the forefront of the epidemic, and you can see the numbers increasing exponentially. But dramatically, you'll see that the Eastern Cape has surpassed Gauteng in terms of the actual numbers, and KwaZulu-Natal lags behind. The reason for that I will explain in the next few slides. Looking at these figures, and if we focus on the last section of the slide, based on yesterday's data, you will see that approximately 5 to 10% of the cases actually been admitted, of the new cases or the active cases are admitted at hospital. And of those, of the admitted cases, at least 10% of those require intensive care units, and 50% in some provinces of the patients in ICU require ventilators. So even though the disease might not be seen as a big in terms of the numbers itself, but the number of patients requiring intensive care units and ventilators is actually increasing, which is creating a huge burden on the health system. Again, I'm not going to go in detail on the slide, but it speaks to what Professor Yunus Moosa mentioned, that the majority of the cases that we've seen are above the age of 25 and predominantly female, as depicted in this example. Now, we all hear about hotspots. And when we hear about hotspots, there are certain regions of South Africa that carry the majority of the burden. And at the top end is the city of Cape Town, followed by, but when we convert the numbers into percentage per 100,000 population, you'll see as the burden is increasing everywhere else, you'll see that Eastern Cape has a higher numbers in its metropolitan. The problem with the KwaZulu-Natal data is that there's lots of gaps in the data because the data is not being released daily. So we actually don't have a true picture of the number of cases that are in KwaZulu-Natal. We only get to know the number that are confirmed. But when you look at this next slide, and I think this is the most important slide of giving us the actual situation. If you look down the slide, you will notice that the majority of admissions being reported are from private health facilities. You will find they are very minimal in each of the province except the Western Cape that has a number of private public facilities also reporting. You will find that we have no data as to the actual admission within the public facilities. So therefore, many people have this assumption that we prepared a lot of beds, but nothing is happening, but we don't have the data. The next slide that we need to look at is that we're almost reaching 1 million tests that have been performed. And on average, we're doing about 30,000 new tests daily. But the biggest problem is that the time lag between getting the results in the public laboratories versus the private laboratories. 2 weeks ago, the backlog was up to 97,000 tests that were not processed. And that's a major downfall in the results that we have. Now, if we look at this, and we would all like to learn from what's happening in the Western Cape, so we could actually improve the way that we handle cases in other provinces. So one of the things is, if you look at the way that the Western Cape health system runs, runs better than most other provinces in the country, despite what we might think. They have done more testing. Their systems for reporting are much better. And that's the reason, one of the possible hypotheses that why we're getting lots of reports out of cases. But the tourist season was in January and February. And as Professor Moosa mentioned, there were lots of asymptomatic carriers that actually seeded the virus in the province. We also had episodes of high intensity spread at a pharmaceutical company and supermarkets that resulted in widespread community transmission. Now, when we look at other diseases like TB, which is very high, the high incidence in the Western Cape, then we need to go back and look at the social determinant of health. Alcoholism plays a huge part in people gathering together, and as a result, could have resulted in this increased number and exponential spread. And one of the other hypotheses is that the dampness of the area. Now, when we look at the deaths that occurred, and this is based on yesterday's data, you'll find that 53% of the deaths are in males, and the majority of them are in the age 50 and above. And people that are dying, there are a number of comorbidities that have been pointed out by Professor Moosa in terms of what the reason for the high mortality. And you'll see that patients with diabetes, with HIV and hypertension, as well as chronic kidney disease, are at a greater risk of having a COVID-related mortality. This slide, just to go quickly, tries to provide reasons as to why there is a difference between the mortality between males and females. And one of this thing is related to the pre-existing comorbidities as well as the high-risk behaviors such as smoking, alcohol use, and certain occupational exposures. Now, when we focus at the Muslim community, we will find that even though we comprise 2% of the population, the current mortality in the Muslim community is around 80 of the 1,000, and there's probably another few that happened today so it represents in the region of 8% of the mortality for a community that's 2%. But we can't read much into this because of the fact that we don't have data about people might be dying from cardiac complications or other things, what the current mortality figures from those are. But this is just to paint a picture that the Muslim community is not immune to the COVID virus. Okay, so now I'm going to move on to the next few slides. And we need to understand that at this current moment in time, South Africa is at stage 4, which means that we have widespread community transmission of the COVID virus. The next few slides, I want to explain a phenomenon that I think is important for us to understand and to curb our impatience, because we hear lots of people saying, we've done all this planning, but nothing has happened yet. Or the planning has been done, but the negative effects of the planning are certain other aspects that I will discuss. So we have this phenomenon that we call dynamic complexity. And a health system is one of the classic examples of what we call a complex adaptive system. Now, this is a situation where the short and long-term consequences of the same action are dramatically different. So two people, like we say with the disease, two people can exhibit different mortality or morbidity, or the disease might have different effects on two people. In the same way, when a policy is planned, the effect might be different. The consequences and even well-intended actions might lead to non-obvious counterintuitive results, which we've seen because of the lockdown. So what makes the health system a complex adaptive system? Firstly, it's not predictable. The changes are not linear or easily predictable. So for example, I might give you the medication, but it might work differently and I have no guarantee that it will work. The second problem that arises is that even though we might have a large health program, but because of the impatience of people, we will get rumors and different type of messages that are being sparked around that will create doubt. In some instances, they may create riots or spark a strike. The next thing that we need to remember, that before we started the lockdown and before we did many things, we had a lot of forecasts and models. But these can be done to predict effects on health and poverty, but they're not cast in stone. They're actually modeled that allow us to determine what we expect. So what will be the best case scenario and what will be the worst case scenario. An important point to remember that the consequences of the actions are not immediately visible. So decision makers tend generally to take certain actions while trying to ensure that we make the system reach a desirable state. So not every action that we plan is perfect. And the last point that I want to stress about this is that there is a huge human element in whatever we do. So that's what makes the system that we're evolving a very complex system. And as a result of this, we get lots of friction and lots of dynamic views. Now, one of the things that we need to remember is that we went into this period of lockdown, and many of the professors and many people, although they agree with the lockdown, understand that this lockdown had also its unintended consequences. But some of the effects that people will say, and one of the examples that I normally give is that people complain that this is we did the, the lockdown at the wrong time, and we allowed our airports to stay open. So again, looking at the dynamism of the system is that if it was one of my relatives that was stuck overseas, I would be the first person complaining of why this lockdown was done now. Couldn't they have waited? Couldn't we have brought people back? So it's about your personal prerogative and how it affects you. But the critical thing about this entire thing is that even though we did the lockdown, the idea was to build up our health system, but it's not 6 weeks and 8 weeks, we cannot build a health system. Another impact or unintended consequence is that even though we put in the best system, though we have come up with policies and procedures, the slow release of results has actually snatched our chances to slow the community infection. As a consequence of our renewed focus and resources being diverted towards COVID, we find that other diseases and other elective procedures are actually lagging behind. People are saying that the hospitals are starting to see cases of malnutrition because students that benefited from the meal a day at school are not getting that meal anymore. And as a result, we're getting lots of malnutrition in the community. I cannot speak on the economic consequences, but we know it's very dire because lots of people are being retrenched and lots of jobs are being lost. Now, the question then is COVID-19 a big hype? Remember that our Iman shows us, and our belief is that everything happens and all absolute knowledge only belongs to Allah. No predictive modeling is 100% accurate. So all diseases and all conditions that we live on the surface of earth will come from Allah, and if it's destined for us, we will get it. But based on the current evidence, the disease is a reality with a potential to spread. When we look at the lower than anticipated figures, we need to look deep dive into the accuracy of the data that looks at our current status. So there may be issues around that. And we need to remember that this is an evolving disease. Importantly, is when we need to look at what we're looking at. If you look at these graphs, you will see that these graphs present the other provinces except the Western Cape. And you will see that we've seen exponential spread. After the 28th of May, you can actually see that the levels of increase in the number of cases. And dramatically, you will see what it took Gauteng 96 days to reach, it's taken Eastern Cape 79 days to reach. So different provinces will exhibit different rate of spread and disease transmission. Going forward, we need to remember that not everyone that is infected with COVID will spread the virus. We're likely to see clusters of cases and spreads originating in places of workplace, supermarkets, funeral, hospitals, and places of congregation. So that again goes to speak to what Professor Moosa has said. We're going to have a lot of asymptomatic people that we screen that won't display the symptom, but might be hyper spreaders of the disease. This is not, so we need to remember that for all of us, no matter what intervention comes and when it comes, we need to take collective responsibility. And if we don't do what is requested from us or we're requested to do, we will have a quicker transmission and a greater peak with more mortality and morbidity. So we need to remember that the 5 important principles. Firstly is hand sanitization. Hand sanitization, which looks at washing your hand with soap and water, not touching your face and hands frequently. If you're coughing, use the elbow to retain your cough. Social distancing, and staying at home if you're unwell. The key purpose of the mask is to not to prevent you from catching the disease, but it is to prevent you from spreading the disease. And this is especially important when people are asymptomatic. But one thing is to advise wearing the mask. The other is to wear the mask correctly, which means that your nose actually needs to be covered. So my last parting word is that we cannot be complacent, because remember, human beings have this situation where we will practice today, and as time evolves, we will practice less on these measures. So we cannot be complacent, because complacency is our worst enemy. And as has been presented by both Professor Yunus, Moosa, and what the data is showing us, this is a disease that's out there, but there is no need to be panic. We need to start to learn to live our life normally and get adjust to the new normal, and we need to stay safe. Jazakumullah khairah.
Jazakallah khairan, Dr. Ozayr. We'll have a few minutes, inshallah, for Q&A right now. We do have some related Q&A on our screen, on our chat, as well as those that have come in earlier. Dr. Ozayr, I don't know if this is directly to Dr. Ozayr or Dr. Yunus Moosa. I think you all can decide between yourself. We have supposedly, according to the data, crossed 1,000 deaths. You mentioned in your presentation that, Dr. Ozayr, directly related to COVID. However, it seems that people are reporting that the death certificate that they are asked to sign off as COVID, but the patient displayed no signs of COVID. It was a heart attack, it was even an accident, and people are asking to sign on as COVID. And these particular deaths are now going into the national registry, or they are now being calculated as COVID. The number itself, whatever model medical personnel are using, it's on its place. But this number itself, how can we trust this number here? It seems to be far less than what it actually is. Your comments on that?
Uzair, you want to take that, or you'd like me to take that?
I think you should. I think
okay.
You have a bit.
No problem. Okay. So essentially, you see, I mentioned that patients can present to hospital being pre-symptomatic, or patients can present to hospital with the asymptomatic disease. And that has caused a great deal of anxiety amongst the healthcare workers. Because the last thing they need is for somebody to slip into the hospital with COVID without being, or rather with secreting the virus, but without being COVID, because COVID is the disease, SARS-CoV-2 is the virus. So the last thing they need is somebody to be in a ward where no one has COVID and have somebody secreting the virus. So there has been this tendency to test people for COVID, even though they don't come in with symptoms of COVID. And I'm sure most people would understand that anxiety. So that if somebody tests positive, they can then isolate them. And if they're negative, they can allow them to mingle with other non-COVID patients. So if, for example, somebody comes into the hospital with, let's assume, chest pain, and within a few hours, they die from that chest pain, but they have been tested, the law requires you to consider them a COVID suspect because you tested them. Now, if that person has been tested as being COVID positive, the process that needs to be followed for the burial of that person should be dictated by the outcome of that test. So if a Muslim family comes to me and I'm faced with a situation where I'm clear in my mind that the death is unlikely to be related to COVID because he's had a heart attack, but that test is pending, I'm put in a very difficult position because I don't know what to write on that death certificate. So I will then advise the Muslim family that this person has died. We've actually got to wait for this result. Once we have this result, then we can decide how this patient should be buried. So we have got one of two choices. Either we put down on the death certificate, suspect COVID, or we wait for the result and then write down exactly what the result states. Unfortunately, everyone is in a hurry to get the deceased buried. So they will go for the option of putting suspect COVID. That's no fault of the system. That's no fault of the doctor. That is the desire of the family to follow the sunnah. Really speaking, What the family should say is that he's been disingenuous about what's been put on that death certificate. Let us wait for the outcome of that result and then decide how to proceed. So we are all caught in a bind. I think everyone is complicit in whatever in what we write on the death certificate. And it's not that the medical fraternity is trying to inflate numbers. It's we're trying to find a fine balance between pleasing the family's desire at a very emotionally vulnerable time to make a decision about burying their dead, and at the same time trying to be true to what the diagnosis is. I believe that this has happened. And I believe that it is not in the majority, it's in the minority, because most people that present to hospital and then die usually die more than a day after being admitted, by which we have the COVID result. So,
Dr. Yunus, at the same time, if this is actually happening, let's say, for example, a person's test later on proves that they were not COVID, but because you wanted an earlier burial, COVID suspect was placed there. As far as the national results are concerned, will this be recorded as a COVID death?
well, you see, the whatever is recorded in the national statistics will be what's on the death certificate. And again, I stand corrected. Maybe there's somebody who understands medical law better than I do. But I don't think legally you would be allowed to go and change what has been written on the death certificate. You understand?
And that's where it brings our concern regarding public health, Dr. Ozayr in particular. The public relies on accurate reporting, especially when it comes to the deaths of people in regards to COVID. I mean, this obviously is going to create a particular mood in the public circle that if you have maybe 1,000 deaths, but it's potential that you maybe have 700 or 600 people that died from COVID directly, but other people rush to put it on their certificate. So rightfully so, you are going to have a inflated figure in the eyes of people, although it may not be significant, but it is significant in public reporting.
If I can just come in there before you do, Ozayr, I just wanted to say that if we want to be true to the statistics, then really speaking, our community needs to understand that there is a time frame within which they need to wait for that result. And I promise you, at an emotional time like that, there are very few people that are prepared to wait. You know, their desire to get the buried as soon as possible is so great that they become complicit to what is being put onto that death certificate. Ozayr, you can address the other question.
Yeah, so I think you raise an important point, and even Moulana raises the point about data. You see, at the end of the day, the reality is when you look at the death certificate, it has a primary cause of death, which might be the cardiac failure or the kidney failure or whatever it is, and it has contributory causes to death. So in analysis that the Department of the statisticians South Africa, when they analyze it, when we're going forward, they look at the primary cause of death. But because we faced with a pandemic at the moment, we including people that are under investigation as well, if we haven't got a complete test, you know what, in the bigger picture, even though the data might be inaccurate, it will be a minority of the population. So it again comes to what we're going to use the data for. There is an emotive aspect versus the actual research or the actual utilization of the data. And in any of the situation, even when you look at the results that are presented every day and what's coming out, the data is not 100% accurate. So we're not going for 100% accuracy in the bigger picture.
Doctor, is also at the same time, another question coming through on my chat is that we spoke, or it has recently been reported that private facilities are collecting 16,000 Rand per day for the admission of a COVID patient. Now, the fact that there are very few COVID patients in public facilities, but yet majority of them seem to be in private facilities, it does, of course, create a suspicion that you are trying to push more people into private facilities in the interest of people siphoning off that 16K that's available. Now, granted, this may not be a medical related question, it's more a corruption related question. We probably might need to have an ombud over here instead of you guys, but it's there and it has been reported today. And you know what, noting that the history of our country, it might just very well be likely that something is cooking here.
Okay, so there's two aspects. Okay, one is the aspect that you're putting through, but the second thing we need to look at the profile of the people that are actually were the primary infected cases. So those were people from the higher socioeconomic circumstances that all travel overseas and majority have medical aids. So their first point of care was, where do they go? They would go to the private facility and not to the public facility. But now, as we've seen the spread in communities that are less uh, that do not have medical aid, we will actually see the shift in the balance towards the public facility. So what you said may be correct, but there's an alternative explanation to that as well.
The medical facilities or the ICUs, are they actually full? I mean, look, maybe there are certain hospitals, Tigerberg or Mill Park, that have reported plenty of C19 patients. But currently, as we speak right now, are your ICUs filled with C19 patients?
Okay, if I can just come in there. Firstly, I'd like to know who's giving the 16,000 rands. I mean, who has the desire to inflate the numbers and give 16,000 rands? If we think it's government, I have serious doubts about them giving it. If it's medical aids, again, why would they want to do that? So anyway, that aside, I understand what you are saying. I mean, I'm working at King Edward Hospital. We've had approximately 15 to 20 patients with COVID since the beginning of COVID epidemic. So we're all sitting and waiting. What is going on here? But you must remember that if we don't prepare for the deluge and it comes, the entire population is going to ask you, why didn't you prepare? Could you not see what happened in China? Could you not see what happened in Italy? Could you not see what happened in the UK? What's going in the United States? Can you not see what's happening in the Western Cape? I mean, clearly the writing is on the wall that this is coming. It's just a matter of time. So really speaking, it would be very irresponsible of us not to see all of this happening around us and not preparing. So I understand the frustration. People are not seeing it. But I'd like to be wrong, to be honest with you, because if I'm wrong about this epidemic or this wave of epidemic hitting us, then many lives will be spared. But I am concerned that having seen whatever is going on in the rest of the world, there is nothing, absolutely nothing unique about our population that we should be spared this infection. So I'm concerned that it's coming. It's just a matter of time.
Okay, doctors, I doubt. I'm just going to check up this chat one more time before I end this Q&A officially. I think we are using our chat here to collate and to correct our Q&As. Let's see. Okay, if you can just bear with me for a minute. Okay, it seems that Muslim Stats SA has, in fact, or certain stats group have responded by saying that when they record their stats, they only include confirmed cases as opposed to non-confirmed cases. Okay, so that part is fine. We don't actually have another question left, so Doc, I'm going to end this Q&A here right now. But remember, our session is still in progress. I'm sure many of the presenters might just have a small break as we hand it over to Moulana Akoo and Moulana Vanker to conclude. But if you could just stay within earshot in case we have a question that might be penned down correctly, we would be glad to, inshallah, ask our experts, whilst you're online. I'm going to hand it over, inshallah, to Moulana Akoo. Moulana Akoo, of course, needs no introduction on many of the platforms that we are right now. Moulana Akoo has been very instrumental in with regards to the the COVID-19 response when it comes to the distribution of food aid and food parcels from amongst the food community, as well as assistance. So, Moulana Akoo, assalamu alaikum wa rahmatullahi wa barakatuh. Please take it on.
Wa alaikum assalam wa rahmatullahi wa barakatuh. Jazakallah to you, Moulana. And also, I'd like to thank all our doctors and participants. MashaAllah, it's been an amazing program so far. I myself have benefited tremendously, and I'm sure all our viewers alhamdulillah, also benefiting, and all those who will possibly view this recording, inshallah, will definitely benefit immensely. I'd also like to welcome Moulana Vanker, mashallah, who's also a giant in our society and also needs absolutely no introduction. Moulana, welcome to tonight's program. Assalamu alaikum wa rahmatullah.
Wa alaikum salam wa rahmatullahi wa barakatuh, Moulana, and to the esteemed guest, on the program. Hope all are keeping well. Moulana, jazakallahu khairan for the opportunity.
Okay, Moulana, we've heard, mashallah, what all our medical professionals had to share with us in terms of their input. And keeping with the theme of practical management of the COVID-19 pandemic, when we look at it now from an Islamic point of view, maybe if you can share with with our viewers out there, some of the lessons, firstly, that we as believers in Allah subhanahu wa ta'ala take from this situation that we find ourselves in.
Okay, Bismillahir Rahmanir Rahim, nahmaduhu wa nusalli ala rasulihil kareem, amma ba'd. Something which comes across loud and clear is trust and reliance and tawakkul on the Almighty Allah, where Allah has taught us a great lesson for each and every one of us, to once again press the reset button, to realign our lives and to navigate, our lives. And we've heard this, in fact, in the recent past. People who are, amongst the affluent community. And many of them have said, I've now realized, how much do I really need, to survive and live? Allah has blessed me so much. I abandoned my kids, I abandoned my wife, and abandoned everything else. Allah has given me this opportunity for me to, reflect, for me to introspect. And I think this is one of the greatest lessons, that many of us have taken. And let us not forget, those like Moulana Junaid Kharsany alluded to a little earlier, like Moulana Ahmed Akoo, in the Peter area, y'all are doing excellent work there. This initiative, it started during the COVID crisis. And, this is something that is going to remain with us, for a period of time. So I think what is lacking in, in the Muslim community is that we need to find that balance. What I find personally, there is a lot of extremism where you find on one hand, there are those who are they have trivialized this entire COVID pandemic. And on the other hand, you find that there are those who have instilled, such fear, into the hearts of the masses. And I think what Islam teaches us, and this is something which we could adopt in every aspect of our lives, and that is, the middle road. Let us find that balance. I think if we find that balance, then we could work together, to improve the situation of those who are, who are less fortunate. We've seen on social media, I've mentioned it on various, radio stations, the differences of opinion amongst scholars and ulama in the medical fraternity. There are many differences of opinion amongst the medical doctors as well. But as long as we can learn to, I think, respect one another, there are many sensitive issues that that are being discussed on social media, and I don't think this is the platform. We're just trying to look at, from a positive perspective, what are the positives, that we can take out. And, differences of opinion, this is something which is inevitable. It happened from time immemorial. It will happen till the end of time. When we study the lives of the great companions of the Nabi of Allah sallallahu alaihi wasallam, they differed on so many issues, but their hearts were united. And I always say this, I mentioned this many a times, that the definition of the unification of this ummah is not consensus on one view, simply because if any person has this intention of unifying the ummah by bringing them onto consensus, then I'm afraid by its very definition, it's a flawed definition. So we need to learn to respect, the different opinions. Doctors, those who like our respectable or honored doctors that we had on today, the Professor Yunus, Dr. Ozayr, who are quite active in hospitals, and they would tell you what is the situation. Perhaps a doctor, who's serving in a surgery, he would have a different view. Similarly, amongst the scholars and the ulama, I personally, when I've been asked this question, my answer is, whichever alim you have trust and confidence in, whichever medical doctor you have trust and confidence in, listen to him. but do not, it's your personal opinion, but you could be wrong. That opinion could be wrong. So I think if we learn to embrace one another, then we can, we can progress as an ummah. Unfortunately, today we sit on, on WhatsApp, on social media, and we become like keyboard warriors. We start attacking this one, and so we need to respect, the opinion of, the medical fraternity, and we need to strike a balance, when it comes to the scholars and the ulama. Every alim, we respect every scholar, every alim. We should not open up our tongues against any alim of deen. Likewise, the medical fraternity, they have been serving, the community, diligently. And they've been, subhanallah, we've seen many reports coming out. I think as Muslims, the question we need to ask ourselves is, we know of some person or the other, who is affected either by the COVID, crisis. And in fact, I received a call 2 days ago from a medical doctor, and he mentioned to me that there are some patients who have been hospitalized. We need to reflect and ponder. It could be my father, it could be my mother, who's in hospital. And, as a child, you cannot visit your own parents. So we need to reflect. It's a very sensitive issue, and I think we need to, pay heed to that. And unfortunately, today, the reality only strikes us when it happens to me or somebody, close to me.
Moulana, I think you raised a very important point. I mean, I know of somebody personally who mentioned a similar sentiment where that person was in contact with a relative and a family member, and it was discovered that the relative is now COVID-19 positive and has the virus. As a result of that, that person was hospitalized, and obviously everybody who he came into contact with his family and his relatives, all of them had to go in quarantine. And I recall speaking to my friend, and he said that, listen, Moulana, let me tell you the situation. The person tested positive right now is in ICU. His wife is in quarantine. His children are in quarantine in their own homes. Nobody can visit each other. Nobody can get to the hospital. Nobody can give that emotional, physical support that we so accustomed to in society. So as you said, when you face it with the problem, it's a whole different ballgame as opposed to us sitting back and then commenting on really what's happening in society. So I don't know whether we should have a different program with regards to challenges caused as a result of COVID-19, or a sort of program that we're discussing right now, because I think so many more challenges have come about as a result of that. But then also going forward, Moulana, there's so many people that I know of personally, and I'm sure definitely you've had the same experience of people who, in the process of this lockdown or as a result of this pandemic, have brought about so much of goodness in their life in terms of their spirituality, in terms of them reconnecting with Allah subhanahu wa ta'ala. I know of people who've spent more time now with the Quran than they've ever spent in their life. And now we're coming towards what you call more normal life. It's level 3 of lockdown. Who knows, in the next couple of weeks, there could be a drop in that level as well. And we're going to be going back to what they would also term as the new normal. So now how do we look at it in terms of that? Now we're going forward positively as Muslims. For example, alhamdulillah, the masajid have opened with obviously stringent restrictions and protocol that has to be followed. Now, how do we appreciate those favors going forward?
Yes, I think, sometimes we coin these terminologies. Like one person mentioned it. He said, what he speaks about selected Alzheimer's. We've got short-term memory. So, time goes on, and, it's just a matter of, a few weeks ago, we're in lockdown, and, things are beginning to open up, and we've become totally complacent. So I think it is important, going forward, to keep the momentum going. Moulana, like you had mentioned, during the blessed month of Ramadan, we know of many people. We transformed our homes into places of worship. There are many people who reconnected with the Quran after many years. This is an opportunity for us to, keep the momentum going. For example, after the blessed month of Ramadan, we have the 6th fast of Shawwal. One of the many wisdoms the scholars and the ulama have given, to keep the momentum of Ramadan going after Ramadan, to see if a person's ibadah was accepted, to see if there's continuity of that particular action. So similarly also, there's a lot of good, during the COVID-19 crisis, during the lockdown. Mashallah, we look at, the amount of Muslim brothers and sisters, that were feeding families, both Muslim, non-Muslim, What happens after Ramadan? We tend to become very complacent. In Ramadan, we dig deep into our pockets. We become extremely, charitable. In terms, the masajid are now open, like Moulana, you had mentioned, with stringent, conditions, subhanallah. So let us once again, navigate our lives. This is an opportunity for us, to get closer to the Almighty Allah Tabaraka wa Ta'ala. I think what is happening in the world, this is like the hadith Nabi alayhi salam teaches us, as-sa'idu man wa'ida bi ghayri. An intelligent man is the one who heeds the happenings around him. An intelligent person is the one who heeds the happenings around him. The question that each and every one of us needs to ask ourselves: what lessons have I taken, from the lockdown and the COVID, crisis? Perhaps some might trivialize it. Some will adopt a very extreme, view on the COVID-19. So I think my message is, and I mentioned this on various platforms, let us adopt a very balanced approach. We cannot trivialize it. We need to, the hadith teaches, we need to tie our camel. We need to take, the necessary precautions. And thereafter, we put our trust and our reliance on the Almighty Allah. You ask any person, one of the greatest fears, that we have is that if I contract the virus, I potentially could die. But respected viewers, we need to understand that as Muslims, every one of us should have the desire to meet the Almighty Allah, to meet the Almighty Allah. We've seen, people who have been suffering with this virus. There are many friends of ours and many brothers in other countries, the United Kingdom, who were suffering in clinics and hospitals. And, people might tell you that, it's a small percentage, that would die. But we do not want to, go into a situation where, where the doctors have created this awareness. All I'm saying is let us create that balance. Let us create that balance. I think if we adopt that in every aspect of our lives, moderation, when Nabi alayhi salam taught us when it comes to our lives, sulusun li ta'ami, a third for food, a third for drink, a third for air. So Nabi alayhi salam had taught us al-i'tidal, let us take the middle road. And this is the solution. People globally are searching and looking for solutions. So I think, inshallah, let us adopt, the middle path. And, this is a solution to the problems that the world is facing today.
That's very important, Moulana. One of the questions that has come through, Moulana, so the person is asking, is there any evidence that discourages a person following conspiracy theories? Because apparently it seems that many people seem to be omitting safe procedures or stopping to practice on safety procedures simply based on the fact that some people out there still believe that the coronavirus doesn't exist. It's all one big conspiracy theory for a whole new world order. And obviously, we're not discussing politics, and this is not the platform. But any input with regards to that, and also we have our doctors over there. I think I would like to request if any of them are still available, either Dr. Yunus or Dr. Ozayr, if you all can tell us how real, because some people still have their doubts.
Yes, when it comes to conspiracy theories, today there is a theory on each and everything. Every person would give you his own opinion. You go onto the internet today and you can pick up an article on anything and everything. And this is another weakness that we find, in the Muslim Ummah. I spoke about it on one of the radio stations yesterday. We disseminate and we send out anything and everything that reaches us, whether it's verified, unauthentic, reliable, we just send it out. So this is something which is important. Like they say in Arabic, لِكُلِّ فَنٍ رِجَالٍ. Every field has its specialist. So when it comes to, you want advice on any Islamic ruling, then we go to scholars and ulama. When it comes to, a medical, a medical doctor will not open the books of law and fight his own case. Likewise, an attorney will not open the books of medicine and try and treat himself. So this is the problem today. I think, we just need to, we are masters in our own field. We should stick to that and leave it to the experts. So the doctors.
Masters in every field, Moulana.
Yeah. Yeah, and I think perhaps maybe some of the doctors, Prof. Yunus, you could share your thoughts on these conspiracy theories, and there are many of them that we've seen recently.
Everyone is an expert. There are people who really believe that the world is flat. Really. So people are going to come up with a whole host of theories, but we have to bank on hardcore science. And hardcore science clearly demonstrate that there is a viral infection, it is spreading, and we have got so much of communication around the world. We know that this virus is causing ravaging deaths all over the world. So clearly, this is not something that has been made up by somebody. This is real. And if we do not respond to this epidemic, then clearly we are being irresponsible. This reminds me of the time in 2002 when South Africa was denying HIV. I mean, the same thing. And see how under what criticism the government was placed for denying HIV. Do we really want 80? I mean, we want a large proportion of our very vulnerable population, the poverty-stricken, the HIV positive, the patients that have got renal disease, the elderly, to die, and then turn around and say, well, why didn't they do something? Why didn't we do something? It would be totally irresponsible to have that attitude. Like I say, we rather be over-prepared than under-prepared. That's how I feel strongly about that. Thank you.
Yes,
So, Dr.
and I
Ozayr,
think
anything from your side? Moulana can continue, Moulana.
okay. One of the reasons, and to be, I think, objective, this is a comment that we've heard from many people, is that 6 weeks ago, 8 weeks ago, there were certain predictions that were made, by certain medical doctors that watch what happens in a month's time or in 8 weeks' time. 40,000 people would die and 80,000 people would die, and I think as a result of which, I think the death toll at the moment is around 800. Moulana, I think it's about 800 or so, plus minus.
Over 1,000. Over 1,000.
Over 1,000 that have passed away. So perhaps I think Dr. Ozayr could. I think let's we throw a googly and a curveball. How would you respond to that?
Okay, so Moulana, you know what? As I mentioned before, life and death is in the hand of Allah, and we all. So predictions are not 100% accurate, and you have to look at what was presented. It was about what's the worst case scenario and what's the best case scenario, and what can go in between. And as I mentioned in my presentation, in the health system, in the healthcare, 1 + 1 is not equal to 2. So no matter what predictions we make or what we say, the general feeling about the prediction was to create awareness to the government that they needed to do something. And that's the worst case that could have happened. And you prepare for the worst case and hope that it doesn't happen. So that was the reality of the prediction. And I think if we delve too much on the predictions and the forecast and whatever, then we will lose focus of what we need to do.
Okay, doctors, I need your input here. There's two questions that have come in. One is, I'm trying to get the pronunciation of what has been posed here. Does hydroquinone, is that a cure for COVID-19? I'm sure I don't know whether you're familiar with the term
Yes,
or what
it's hydroxychloroquine. Hydroxychloroquine is actually a drug that has been used to treat malaria. It's also a drug that's used in rheumatological diseases to treat people with lupus, rheumatoid arthritis, for joint pains and rashes. So it's a drug that has got toxicity attached to it, as well as a drug that shows benefit in those diseases. But you must remember, those diseases have got quite a bit of morbidity. That means it causes a lot of symptoms in the patient, as well as restricts the quality of life, and the diseases that cause death. So the use of a toxic drug in that context is justifiable because the benefit from the drug outweighs the negative aspects of the drug. And I think at some point early on in the epidemic, there was some indication that this treatment could have benefit in COVID. So in China, they actually were empirically using the drug. Empirically means without much evidence, they decided to go ahead and use the drug. And since then, there have been several studies that have looked at the value of this drug. And what it's been found is that the toxicity of the drug outweighs any benefit. In fact, they couldn't find any benefit. So they took a group of patients without using hydroxychloroquine, a group of patients that they use hydroxychloroquine, and then compared the outcomes in terms of morbidity and mortality, as well as toxicity. And they actually found that in the group that used the drug, there was higher mortality, suggesting that this drug might have actually killed people rather than benefited. And just last week, I believe there was a study that looked at preventing treatment, where they took doctors that were at high exposure to COVID, and they had a group that was taking hydroxychloroquine and a group that were not on hydroxychloroquine, and then compared those two groups, and they found that there was no benefit. So my overall understanding as it stands at the moment is that hydroxychloroquine does not have any benefit in preventing the disease or treating the disease.
Hydroxychloroquine. Okay,
Chloroquine.
trying to get the product. Okay,
No problem.
doctor. One more important thing. We always stressed out with regards to how we're going to manage the month of Ramadan in the state of lockdown and with this pandemic upon us, and we passed to the month of Ramadan. Now we're not far away from the season of Qurbani, so a question has come in. Will there be any protocols or what's the way forward? I know obviously as Ulama we're going to sit down and we're going to have a look at this whole thing, but since we are on this panel right now, with regards to the cutting of Qurbani and COVID-19, now what are we looking at with regards to that from a medical point of view? Obviously, as I said, as Scholars Week, we're going to sit with that challenge ahead of us. But from you, any input from you all with regards to that?
Okay, so that falls under the ambit of environmental health. And so at this moment in time, we have no evidence that COVID is spread to an animal. So the second thing we need to consider, so the biggest risk on the day of Qurbani is going to be the crowds that gather at the abattoirs and the crowds that gather around the animal. And as I mentioned before, that the spread of the disease now is going to be around congregational activities and places where people gather. So once we have crowds and people not distancing themselves and people not wearing face masks and everybody just intermingling, then the likelihood that those events will become a potential for a super spread of the virus is greater. So in terms of the actual slaughtering of the animal and whatever, there should be no objections or implications, but it's the way that we actually perform the act will be the big issue.
Well, I'm not setting the cat among the pigeons, but I'm also trying to be practical. Normally, if we take a typical Qurbani scenario, you got two or three brothers holding down the animal, you got somebody else cutting, then you got few people skinning. There's real challenges that we are going to face.
Yeah, but in that situation, everybody has to wear mask correctly, and with the wearing of the mask, there is a potential for the reduction of the spread.
You must remember, unfortunately, the precautions we take, we never say the risk is no risk. We always talk about reduce risk and increase risk. So if you have 3-4 people that are within a meter of each other and for a prolonged period, meaning more than 15 minutes to half an hour, and if one of them is an asymptomatic carrier or secretor of the virus, then there's a good chance that the other people would have significant exposure and get infected. So, Qurbani is going to be just a few weeks to a month or so away from us. I cannot imagine them allowing free reign to have this type of gathering without imposing any restrictions. So I think what Ozayr says is very true. There will be restrictions around that.
Okay, Jazakallah so much. Once again, we'd like to thank Brother Ahmed Asmal, alhamdulillah, who was very instrumental in putting this whole program together. May Allah reward him for his effort and time. And also to our esteemed doctors, Jazakallah, you all with us from the beginning. May Allah subhanahu wa ta'ala reward you all. We'd also like to thank Moulana Junaid, Moulana Vanker, Jazakallah so much for the input that you shared with us this evening. We make dua that Allah subhanahu wa ta'ala accept it all. Before I forget also our Qari Sahib, mashallah, who started off the program with a beautiful recitation of the Quran. Dr. Ozayr and Dr. Yunus, Jazakallah khairan. May Allah accept this program and make it a means of benefit, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.